Hello everyone, I'm back and this time I'm presenting before you the webinar which was conducted on 13 September 2020 in association with the Indian Dental Association on its centenary celebrations. It's been a while I have logged on to my channel with a new video, so here I am with some exciting new content on complete dentures, explaining the importance of conventional protocols in making a complete denture and moving towards adopting modern techniques and alternatives was the need of the hour, is what I thought. Do continue watching my videos on my channel. I have been requested to make videos on how to achieve suction effectiveness in the lower arch. I will soon upload them. Moving ahead. So why a discussion on dentures today? What is the rationale for its discussion? Well, a lot of cases and scenarios can be solved through fixed prosthodontics, either through a support of natural teeth or through implants. But edentulism is on the rise and more than ever. Despite of some excellent endodontic outcomes we say day in and day out, the overall edentulous patient pool seeking the dental treatment has increased drastically. Majority of the patients, even in urban areas, present with multiple missing teeth and some with a few remaining teeth with hampered periodontal status. Also, contradictions to implant therapy would certainly remain. And complete dentures, don't you think, are the basis for a well-constructed full arch implant therapy? So why don't we start with complete dentures first, plan for implants later. Of course, we do rush for prescribing a CBCT report to start with whenever we see a full arch edentulous patient, and an implants could be a part of the treatment plan. But my suggestion would be have your infrastructure ready and then possibly think about implants. So let's see how a well-made complete denture looks like. A mandibular denture, let's say the more difficult one of the two, must have teeth arranged in harmony with the musculature that's within the confines of the ideal zone or the neutral zone, as we say, and the denture base gradually merging into the surrounding tissues of the foundations and the surrounding musculature. It really does not matter if you're including the implants within the confines of the prosthesis or not. Let it be a ball and socket attachment, a locator, or even if it is a complex splinted, milled or a casted framework with retentive elements on the top. The principles of the complete denture, impressions, jaw relation records, trial, etc. remain the same. The same goes with overdentures supported on natural teeth with a splinted header bar bearing nylon clips, for example. So the scenario is just the same, whether it is implants or natural teeth. So today, the focus of my session on dentures would be utilizing the conventional wisdom and adopting alternative modern technology in creating a prosthesis which serves our patients for a long time. Let's start with the basics now, the traditional approach. The approach which has been taught to us in our colleges, in our dental schools. Let's see an initial clinical presentation. Now this is how usually patients present to us. Maxillary ridge with small depressions all over, suggestive of extractions done a few months ago, isn't it? There are scenarios whereby ridges are completely resorbed, lacking distinct anatomical features, suggestive of extractions done a while ago or suggesting a very long usage of dentures. But now this one over here is a freshly extracted case a few months ago. I always would want to have a glance from the frontal and lateral aspect when the patient moves the ridges closer. It is absolutely essential. For one, the operator may be able to judge the ridge relation. Another feature which can be checked is the interarch space for the denture teeth, for the denture base. Also, if the patient is really skeletally prognathic, or whether it is just a pseudo relation which patient has developed over years of his edentialism, can be easily found out with this view. Now, this here is the usual workflow with conventional dentures. We start with the maxillary and the mandibular primary impressions using a medium fusing impression compound. There are various companies to it like Wident, DPI Pinnacle, etc. Mind you, these really work well. And what you do on top of it, after pouring those primary impressions made with compounds, you make custom trays with or without tissue stops. You move ahead with the impression making for the upper as well as the lower arch. Either you use light body, an addition or a condensation silicone light body, or you go ahead with the conventional zinc oxide eugenol impression paste. There are a lot of scenarios where ZOE impression paste would provide you with a good amount of retention. Well, who says this method is flawed? I would still continue using it for decades to come. Well-made stone casts with even land areas, right, are still preferred by prominent labs across the world. It not only preserves the borders a patient has molded, but it also helps us identify the various landmarks of the edentulous foundation, and in turn helps us make occlusal rims and record bases with right specifications. So you see, it is a cascade of events, the complete denture fabrication process, right? So we move ahead with trial after the jaw relation is completed, and then we go ahead and deliver the dentures. Now this is the conventional protocol. Whatever it is, conventional or the modern approach, focus on the foundation right from the start is very essential. If you see the image on the left, it has a primary impression. Now what is a primary impression? A primary impression is nothing but an overextended final impression. If you see, both the impressions more or less look the same, but the PI is an overextended version of the final impression. Or I would say a final impression is the rightly extended primary impression. Impressions are to be made by the dentist, not the patient. It is us who are going to load the impression compound or the alginate on the tray, shape it up in a preliminary manner, and then insert it inside the patient's mouth, and then we ourselves are going to position the tray in a way that it results in a perfect primary impression. Primary impressions can be made through compound or through alginate. Whatever it is, try to mark the PPS, which is the crucial area for the retention of the maxillary dentures, right from the start in the primary impression itself, so that it can be transferred onto the primary model, the stone model. Primary impression can also be made through impression compound, then scraped, and then lined with alginate in those cases where the ridges are extremely resorbed. Now, if the ridges are resorbed, there isn't going to be any detailed anatomical landmark registered on the primary impression. So in order to achieve those smaller details on the mandibular ridge, which usually is the case where resorbed ridges are found, we scrape the tissue surface or the intaglio surface of the impression, leave the borders intact. Mind you guys, leave the borders intact and then line it with an alginate. Let's start with the registration of the final impression step by step. I usually prefer starting from the distobuccal region. Sometimes I include the retromolar pad, moving ahead on both the sides bilaterally, I then complete the anterior region. The lower anterior region has got a strong muscular activity, which is the mentalis muscle. We need to mold our border in such a way that we conform to the activity of the mentalis. Some patients may have a strong mentalis function, some don't. Then I start with the lingual region or the distolingual region, that is the retromylohyoid fossa region on both the sides. I slowly move towards the mylohyoid region. That's where the mylohyoid ridge is the most prominent. Now, mind you guys, mylohyoid ridge serves as the muscle attachment for the mylohyoid muscle. And then I move towards the anterior alveolingual sulcus or the pre-mylohyoid region. Now, this is the way where I complete my bottom molding, and then I remove my spacer. So all these times the spacer was intact. Now, when it comes to the posterior areas of the alveolingual sulcus, what is alveolingual sulcus? It is divided into three areas, that is the anterior, the middle and the posterior, or the pre-mylohyoid eminence region, the mylohyoid region, or the retromylohyoid fossa. The two posterior regions are actually easily recorded by the patient themselves using the swallowing motion or a mild lift of the tongue. But the anterior alveolingual sulcus is when the exaggerated function of the tongue can be performed and the patient be asked to touch the upper lip or place a thumb of the operator onto the upper lip and let the patient touch the tip of the tongue. And that's how the completed border molding looks like. Mind you, a wash impression needs to expose all the border molding all the way. Now this actually confirms that your border molding was at the first place correct. So wash impression just follows the molding. We have a gamut of challenges when it comes to the initial presentation. Almost always those moving towards a completely edentulous scenario first come to us with many complexities. It is how you plan the steps for the patient that matters. Let's take a particular scenario amongst all these challenges where the patient has the upper anterior and a few posterior teeth remaining. All of them are not in a very great shape. There is periodontal breakdown. There is extensive gross decay on those canines and the premolar on the left. Well, all you know, there was a central missing, and then there is a collapse of dentition into that region. There are a few anterior teeth remaining in the lower arch. So how do we plan it? Well, we had implants in our mind for this particular patient, and she was seeking upper and lower full arch fixed implant therapy. In such scenarios, what we did is we tried to retain the upper anteriors till the end, and we planned for an immediate denture. It's because this patient had a mind fix that I would want to retain the upper anteriors till the end. So in that case, I extended those upper anteriors a little, moved till the premolar so that I could preserve the jaw relation till the end. Let's see how this case shaped up. Let's see the occlusal view for the upper and the lower arches, a few scattered teeth here and there, which could be used to preserve the vertical dimension while make the shift into an immediate denture or the immediate denture prosthesis. We went ahead with final impression with the teeth intact. Okay, mind you, you need to have the posterior palatal seal area. It is mandatory to record the post-dam area, which is our best bet towards achieving a positive seal and our primary aid in retention. We then move towards the jaw relation. Meanwhile, create a positive platform for her in the lower arch. Okay. So what I did was I went ahead and provided her with fixed provisionals in the lower arch as implants were planned for upper and lower arches. Then went ahead with the immediate denture for the upper arch. The idea behind an immediate denture is a good communication with the technician. we need to primarily mark the midline as we would lose it in the course of the treatment. Also, mark a few things on the stone cast for the technician yourself, like the facial midline. It's because we have seen the patient transfer it onto the model. The interpupillary line, the high lip line, the gingival line. Now, the high lip line and the gingival line would actually help you choose the right set of teeth. Mark X on the teeth to be extracted, mark O on the teeth to be used as overdenture abutments. But in this case, we did not use any of the teeth as an overdenture abutment, so we extract all the teeth. But before that, we need to do a posterior try-in. Guys, this is the disadvantage here with the immediate denture, that we do not get an opportunity to do an anterior try-in. And then we moved ahead with extractions. Now, on the day of extractions, we delivered her the immediate denture. What I usually do is I use the GC soft liner. Soft liner from any other company can be used, which actually acts as a cushion towards the extractions. And then this also improves the initial seal and the confidence with which the patient wears the denture on the first day, that is on the day of extractions itself. Post-operative instructions include not removing the denture by the patient for the first 24 to 48 hours. Let the patient come back and visit you for a follow-up. Check out those areas which have been extracted. Okay, and this is how the final insertion of the prosthesis looked like in her mouth. If you carefully see, I have been able to preserve that midline or closely match the patient's midline with the denture midline. Now, modern alternatives for impressions. Well, the basic principle remains the same: preservation of alveolar ridges, whether you use impression compound or whether you use alginate. With alginate, what we can actually do is we can inject some softer alginate or an alginate which has a better flow into the patient's mouth, and then use a little more consistent alginate onto the tray and place it inside the patient's mouth. Now, what it will do is it will help us preserve the principle, that is preservation of alveolar ridges as stated by Boucher. Here we have an impression with Accudent XD, which used to be a product from Ivoclar. Unfortunately, Ivoclar has stopped producing it. Correct me if I'm wrong, guys, but I am unable to procure this material. Instead, I have started using something called as Cavex CA37 tray material and Cavex cream syringe material, which does primarily a similar job. Now, I have found some good quality trays from a company called Delta. We have an Indian manufacturer for it. Now, the peculiarity of these trays is that it is completely tissue molded with perforation, so it can be used for alginate. And if you carefully see the lower tray, the images on the right show us that there is a raise of the tray in the retromolar pad region, and the tray has been contoured for atrophied as well as for an average type of mandibular ridge. Also, if you see distobuccally, there is a mesenteric cut. Now, this mesenteric cut would go and lodge into the region where the masseter has the maximum activity, and there is a mentalis knob and a sublingual arc. Sublingual arc will actually record the lower anterior alveolingual sulcus very well, and the mentalis knob accommodates the activity of the mentalis muscle of the patient. So all in all, if you see, it's a very physiological tray. I can connect you with the people who manufacture it here in India. So last year I had an opportunity to meet Master Jiro Abe, who has prescribed a very useful technique for the mandibular arch, specifically the mandibular arch, which is called as the suction effective mandibular complete denture, or SEMCD. Conforming to those protocols of SEMCD, he came up with a tray which is called as the FCB tray. Now if you carefully see the FCB tray, there is no coverage of the retromolar pad region. Now what the philosophy of SEMCD believes in is that the retromolar pad needs to be recorded in the most undistorted form. Alright, no pressure needs to be exerted on the retromolar pad in order to distort it. Now this undistorted retromolar pad will give you maximum amount of retention, provided if you have extended your denture till that region. That is more crucial. Most of the dentures which we see are not extended properly until the retromolar pad region. This is how an impression with FCB tray which I made sometime in the past looks like. Again, similar tray and syringeable alginate were used for making the impression. Next, what is one-step bottom molding? I have been using a material called as Detaseal function from a company called Detax. Alright, now Detax makes a softer version of the addition silicone which can be used for bottom molding. It is available in 2 syringes. You can mix them with bare hands and load it onto the syringe which is provided with by the manufacturer, and in one single step you can cover the whole borders as well as the PPS region for the upper arch, similarly for the lower arch. What it does is it makes your life really very easy. It is something which can be recorded quickly and gives almost similar results as compared to green stick. Now green stick is something which you layer onto the custom tray in sections. In this case, we can go ahead and put the whole material at once. This is how the wash impression looks like after one-step bottom molding. That's how it is. Moving ahead with a combination technique in which I do one-step bottom molding at times for the upper and the lower arches, and then register the jaw relation together. So it saves time. I can combine the final impression and the jaw relation together. I usually take trial appointment or the try-in appointments separately. So what I can actually do is I can go ahead and do the PI, the FI and the JR, all 3 steps together. Now, combination using a needle point tracer. We almost always know that the wax rims cannot be a reliable way to register jaw relation. So we have something which registers point centric instead of an area centric for the patient, and that can be done through Gothic arch tracing. In this case, the tracer which I have is called as the bio tracer, in which we have the pin for the lower arch, the plate for the upper arch, and then there is a small device which can be stuck onto the upper arch. Once we have located the centric relation, the pinpoint centric relation can be perforated with this small plate, and the definitive registration can be recorded. How is that done? I insert some amount of bite registration paste in between the upper and the lower arches. So mind you, I have the final impression and the jaw relation together, a jaw relation which is much more stable as compared to our waxes. Modern alternatives when it comes to interocclusal records, we have the interocclusal records done in the conventional way in which we used to use the Fox plane, right? The concepts remain the same, whereby we have to go ahead and make the Fox plane parallel to the interpupillary and the alar tragus line. So moving ahead with the similar features, we have something called as the occlusal plane analyzer. The occlusal plane analyzer not only registers the parallelism of the occlusal rim to the various planes of reference, but it also helps us orient the midline of the patient. Alright, this is how it looks like. Also, there is something from our very own made in India, where we have an occlusal plane analyzer with a variable attachment. Now there is a hinge here which can be adjusted according to the height of the face of the patient, so that we can actually make the interpupillary line the occlusal plane needs to be parallel to the interpupillary line. So what are the alternatives we have in denture teeth? What is the modernization which we have seen? We have seen highly cross-linked teeth, double or triple layered for maximum aesthetics. Also, there is something called as Novoline from Brident, in which the teeth are already in a preformed shell thin configuration, which can be used to cover those telescopic attachments for overdentures or the components of a casted framework in case of fixed full arch prosthesis. So the technician need not grind the teeth all the way. They are already available in a configuration which is shell thin, aesthetic from the labial and accommodating from the palatal. But I have been using constantly in the practice are teeth from Evoclar, Evostar, Nathostar. Evostar is for anteriors, Nathostar is for posteriors. Phonaris and Phonaris 2 are the composite teeth, not the resin teeth. Monoplane teeth is something which is used for those patients who register an area centric, not a point centric, are unable to do that because of lack of neuromuscular coordination, like in those cases where patients are suffering from Parkinsonism. And what it actually has is, it has teeth which are more flatter and with almost 0-degree cuspal inclination, so that there is some leeway which is given in the posterior segment for the teeth to move laterally or antero-posteriorly in function. What are newer aids in denture insertion? Well, I have been using something called as a pressure spot indicator on the intaglio surface of the denture. Sometimes patients come with highly sore areas. Now the ones which are seen on the left. But when you see the figure on the right, what I have done is I have marked the area which is a premature contact causing soreness in the patient's mouth, and then scraped it off and then relined the area to doubly check whether I have been able to relieve it comfortably for the patient or not. Now, these pressure spot indicators are nothing but addition silicone light bodies, but they essentially do the job of flowing on the intaglio surface of the denture evenly all throughout, exposing those areas which are pressure spots or sore areas. Articulating papers have evolved over a period of time. What I usually use is the Progress 100 from Bosch. Now, with this, I am able to register all the contacts at once because it is a horseshoe shape, and 100 microns is really important. We cannot go more thinner than this. It's because I feel 100 microns should be just perfect for registering premature contacts during denture insertion appointment. Well, abruptly disrupted contacts must be noted and non-functional cusps should be adjusted first. Remember to not adjust the functional cusps during adjustments in centric position, for it may potentially reduce the vertical dimension. Opposing foci can be adjusted in that case. The contacts need to be evenly distributed, something like this. Compare it with an old denture. Alright. Now an old denture looks something like this, whereby the acrylic has compensated over a period of time for the patient. It has adapted itself with its dampening effect, and you can see mild contacts which are not too heavy. Patient has been well adjusted to it over a period of time. So this is what our target should be in the first appointment itself. Alright. Try to achieve these even contacts. Now, let's see an injection molded denture. What is an injection molded denture? It is unlike our normal flask compression molded denture, in which we pressurize the closure of flask in an uncontrolled environment. An injection molding is in a controlled environment whereby resin is flown inside the mold during denture processing under vacuum. Let's see what it is. A patient came to me with recent extractions in the upper and the lower arches. The recent extraction in the lower left region was bothersome, whereby it was right over the retromolar pad region. Primary impressions, just as I showed you earlier, was made using the Accudent XD tray as well as syringe material and using Ivoclar trays. Tentative centric relation was made using the tentric recorder from Delta. Now what it does is it actually registers the tentative jaw relation. Now that's a more appropriate term in this case because we may not be able to achieve a perfect centric relation during the first appointment. But yes, it definitely gives you the near correct vertical dimension. Okay. The horizontal guide is used for mounting the mandibular edentulous cast. Can you see we have mounted the mandibular cast first instead of maxillary, and then this tentric recorder, which has been a upper and lower arch record together from the patient, has been adapted onto the lower arch, and then the upper arch is mounted. We block out the undercut areas, adapt some spacer. Now, this is what is important. We have to arrange for the Gothic arch tracing. We use the BioTracer, which is from Delta again for the intraoral Gothic arch tracing. In this, if you see, I have accommodated the space for the tracer using these gray blocks. And then that spacer is removed and then the BioTracer is attached. The needle point tracing device is on the lower arch, whereas the plate which will be in contact with this needle point is in the upper arch. The record basis with intraoral tracing, pin and plate in its final assembly looks something like this. Yes guys, the tentative mounting which we had done is the guidance for the mounting of the BioTracer assembly. So we analyze the maxillary plane with those conventional principles which we just discussed earlier. We go ahead and make the one-step border molding and wash impression for the maxillary as well as the mandibular arches, and then we perform the Gothic arch tracing. So this is how the combination looks like. The upper and the lower arches registered together at once, and a definitive jaw relation made using Gothic arch tracing. Now, what is a palatogram? What I did in this case, because the patient's phonetic demands were higher, okay, in those cases where a patient is a prominent speaker or a singer, what we can do is we can adapt the palate and insert some amount of soft tissue conditioner onto the palatal surface, which will record the typical lingodental sounds, whereby the tip of the tongue touches the palate. And now this, when it is unset, the patient is asked to pronounce various syllables and consonants. Okay, and then once the soft liner is set, the whole assembly is put into the flask for processing. So the palatal areas of the upper denture will be recorded according to the physiologic impression which you have made using the palatogram technique. This is how the final denture look like intraorally, the lateral views, and this is how the extraoral view looks like. Patient was happy because if you carefully see, we have done some characterization on the labial surfaces of the dentures as well. Now these characterization has been done by the technician using resin stains. Now these resin stains are from a company called Dreway. Now, what do we do additionally for such a patient? Do we try to achieve some balance in eccentric movements? Yes, of course. Try to achieve some balance occlusion. This here is protrusive balance. This here is lateral balance on the working side, on the left working side. That is when the patient has moved her lower jaw on the left. This is right lateral balance. That is, the working side is the right side. Can you see there are a few teeth which are touching each other, and these eccentric contacts help in stabilizing the dentures. Not only on the working side, we have some left lateral balance on the non-working side as well, whereby if you carefully see, the last molar and the to some extent the premolar region are touching simultaneously when the patient is moving. Now the right lateral balance on the non-working side when the patient has moved the jaw to the left. So if you see, we have simultaneous contact during the centric and also during the eccentric movements of the patient. So this is what is called as the balanced occlusion. Digital protocol. My seminar would not have been successful if I would not have told you the modern ways to record the impressions. Well, we can use intraoral scanner to record the arches directly. It may be a little cumbersome method and is still under development. Lot of authors, lot of dentists around the world have been able to achieve reasonable success with intraoral scanning, but it is the model scanning for complete dentures which is the tried and tested method. If you see the analog cast on the left, there is a digital version of the analog cast on the right. Now once the upper and the lower arches are digitally scanned, or the models are digitally scanned and oriented into jaw relation, this jaw relation could be digital, but this jaw relation would be more beneficial and more appropriate to the patient when it is recorded in an analog way. So the result is the virtual representation of the upper and the lower arches. Okay, now this is on the ExoCAD software. Let us have a look at a case where the maxillary arch required a complete denture and the mandibular arch a cast partial denture. An analog jaw relation record was made, which was then scanned and recreated into a virtual articulation. A virtual teeth arrangement was laid down for upper and lower arches. If you see, the teeth have been arranged virtually. This is how I received a 3D printed trine denture, which is nothing but a monoblock, meaning the denture teeth and the base is a single unit. In order to make the trine a little more pleasant looking, there is wax added to the label surface of the denture. Once trine is approved by the patient, we proceed towards manufacturing the final product. If you see, the core concepts remain the same, whether it is a digital protocol, whether the conventional protocol. Okay, we still do have a trine relationship here, whereby the patient and the patient's relatives are shown how the denture would potentially look like. Okay, now the printed final denture consists of two components. One is the tooth bridge and the other is the corresponding denture base. Different printing inks are available for it. Printed dentures are known to be cost efficient than its milled counterparts. Also, the time required to manufacture a milled denture is much more than a printed one. These are the reasons why there has been a paradigm shift in the manufacturing of digital dentures from milling to printing. This is how the final product looked like. So, all in all, I think I have been successful in showing you the conventional as well as the modern digital protocols and all those modern alternatives and steps and materials which can be still used in a conventional manner in order to achieve the best complete denture for our patients. I thank you all for your kind attention. You can connect with me on my phone numbers, my email. As usual, keep on watching and looking out for more content on my YouTube channel, that is Dr. Amit Sadhwani, MDS Prosthodontics. Do subscribe, like and share this channel. I also have a handle on my Instagram profile, that is care_dentures. So long for now. Keep watching. Stay safe, stay secure.